The effectiveness of toothbrushing is best measured by the amount and location of plaque. Over the years, many different toothbrushing methods have been described and prompted as being efficient and effective. These methods can be categorized primarily according to the pattern of motion when brushing and are primarily of historical interest as follows: roll, vibratory, circular, vertical, and horizontal. Roll is a method of modified Stillman technique. Vibratory is Stillman, Charters, and Bass techniques. Circular, Phones technique. Vertical, Leonard technique. Horizontal, Scrub technique. Studies evaluating the effectiveness of the most common techniques have demonstrated no clear superiority of any method. The scrub technique is probably the simplest and most common method of brushing. Patients with periodontal disease are most frequently taught a circular brushing technique using vibratory motion to improve access to the gingival areas. The method most often recommended is a bass technique because it emphasizes circular placement of the bristles. The bass method, you place the toothbrush so that the bristles are angled approximately 45 degrees from the tooth surfaces. This allows the bristles to extend into the gingival sulcus when pressure is applied to the brush in a horizontal direction. Start at the most distal tooth in the arch and use a vibratory back and forth motion to brush. Other methods of brushing, such as the modified Stillman and Charters, are variations of the Bass technique also designed to achieve thorough plaque removal at the gingival margins. The emphasize, they emphasize stimulation of the gingival circulation, which has not been demonstrated to achieve healing results beyond those achieved by good plaque removal. Important: no matter what toothbrushing method is chosen, the manual toothbrush should have soft nylon bristles and a small head. They should be replaced about every 3 months. Next question. Although the average width of the periodontal ligament space is documented to be about 0.2 millimeters, considerable variation exists. The periodontal space is diminished around teeth that are not in function and in unerupted teeth, but it is increased in teeth subjacent to hyperfunction. Again, the periodontal space is diminished around teeth that are not in function and in unerupted teeth, but it increased is increased in teeth subjected to hyperfunction. The periodontal ligament is composed of a complex vascular and highly cellular connective tissue that surrounds the tooth root and connects it to the inner wall of the alveolar bone. It is continuous with the connective tissue of the gingiva and communicates with the marrow spaces through vascular channels in the bone. The periodontal ligament is abundantly supplied with sensory nerve fibers capable of transmitting tactile pressure and pain sensations by the trigeminal pathways. Nerve bundles pass into the periodontal ligament from the periapical area and through channels from the alveolar bone that follow the course of the blood vessels. The bundles divide into single myelinated fibers, which you ultimately lose their myelin sheaths and end in one or four of neural termination. 1. Free endings, which have a tree-like configuration and carry pain sensation. 2. Ruffini-like mechanoreceptors, located primarily in the apical area. 3. Coiled Meissner corpuscles, also mechanoreceptors, found mainly in the mid-root region. And 4. Spindle-like pressure and vibration endings, which are surrounded by a fibrous capsule and located mainly in the apex. Orthodontic treatment is possible because the periodontal ligament continuously responds and changes as a result of the functional requirements imposed on it by externally applied forces. Next question. The sulcular epithelium is a thin, non-keratinized, stratified squamous epithelium without red apex. The epithelial component of the gingiva shows regional morphologic variations that reflect tissue adaptation to the tooth and alveolar bone. These variations include oral epithelium, sulcular epithelium, and junctional epithelium. The oral or outer epithelium covers the crest and outer surface of the marginal gingiva and the surface of the attached gingiva. Again, the oral epithelium or outer epithelium covers the crest and outer surface of the marginal gingiva and the surface of the attached gingiva. On average, the oral epithelium is 0.2 to 0.3 millimeters in thickness. It is keratinized or parakeratinized. The oral epithelium is composed of 4 layers: the stratum basale, the stratum spinosum, stratum granulosum, and stratum corneum. That is the oral epithelium. Now the sulcal epithelium. The sulcal epithelium lines the gingival sulcus. It is thin, non-keratinized, stratified squamous epithelium without red apex. And it extends from the coronal limit of the junctional epithelium to the crest of the gingival margin. Now, the junctional epithelium. The junctional epithelium consists of a collar-like band of stratified squamous, non-keratinized epithelium. It is 3 to 4 layers thick in early life, but the number of layers increases with age to 10 or even 20 layers. Also, the junctional epithelium tapers from its coronal end, which may be 10 to 29 cells wide, to 1 or 2 cells in its apical termination, located at the cemento-enamel junction in the healthy tissue. The cells can be grouped in 2 strata: the basal cell facing the connective tissue and the suprabasal layer extending to the root surface. The length of the junctional epithelium red apex ranges from 0.25 to 1.35 millimeters. Important. The attachment of the junctional epithelium to the tooth is reinforced by the gingival fibers, which brace the marginal gingiva against the tooth surface. For this reason, the junctional epithelium and the gingival fibers are considered a functional unit, referred to as the dentogingival unit. So the dentogingival unit is a combination of junctional epithelium and gingival fibers. Note, histologically, the best way to describe the free gingiva from the epithelial attachment is the fact that the epithelium of the epithelial attachment does not contain red apex and the free gingiva does. Red apex are epithelial projections that extend into the gingival connective tissue. Connective tissue projections that extend into the overlying epithelium are called connective tissue papillae. Next, when there is a change of pH, when there is a change of in the saliva, that causes precipitation of calcium phosphate salts by lowering the precipitation constants. That is a decrease I mean, of this increase of viscosity or decrease of viscosity? A increase in pH. The theoretic mechanisms by which plaque becomes mineralized can be grouped into two main categories. Number one, mineral precipitation results from a local rise in the degree of saturation of calcium and phosphate ions, which may occur through the following mechanisms. Again, mineral precipitation results from a local rise in the degree of saturation of calcium and phosphate ions, which may occur through the following mechanisms. Number one, an increase in the pH. An increase in the pH will cause mineral precipitation because of a local rise of the degree of saturation of calcium and phosphate ions. This is increased by an increase in the pH of the saliva, which causes precipitation of calcium phosphate salts to lowering the precipitation constants. The pH may be elevated by the loss of carbon dioxide and the formation of ammonia by dental plaque bacteria. Again, this increase of pH of the saliva will cause a precipitation of calcium phosphate salts by lowering the precipitation constants. The pH may be elevated by the loss of carbon dioxide and the formation of ammonia by dental plaque bacteria. Now, colloidal proteins. Colloidal proteins in saliva bind calcium and phosphate ions and maintain a supersaturated solution with respect to calcium phosphate salts. Again, colloidal proteins in saliva bind calcium and phosphate ions and maintain a supersaturated solution with respect to calcium phosphate salts. With stagnation of saliva, colloids settle out and the supersaturated state is no longer maintained, leading to precipitation of calcium phosphate salts. Again, so if there's colloidal salts in saliva, they will bind calcium and phosphate ions and maintain supersaturated solution with respect to calcium phosphate salts. With stagnation of saliva, colloids settle out and the supersaturated state is no longer maintained, leading to precipitation of calcium phosphate salts. Now, phosphatase liberated from the dental plaque, desquamated epithelial cells, or bacteria precipitates calcium phosphate by hydrolyzing organ phosphates in saliva. Hydrolyzing organic phosphate in saliva, thus increasing the concentration of free phosphate ions. Now, the second form in which, or the second theoretic mechanism by which plaque becomes mineralized is the seeding agents, which include a small foci of calcification that enlarge and coalesce to form a calcified mass. This concept is referred to as the epitactic concept, or more appropriately, heterogeneous nucleation. It is suspected that the intercellular matrix of plaque plays an active role as a seeding agent. The carbohydrate protein complexes may initiate calcification by removing calcium from saliva, which is chelation, and binding with it to form nuclei that induce subsequent deposition of minerals. So these seeding agents induce a small foci of calcification that enlarge and coalesce to form calcified masses. This is the epictatic concept or heterogeneous nucleation. Note, mineralization of plaque starts extracellularly around both gram-positive and gram-negative organisms. Bacterionema and Veillonella species have the ability to form intracellular hydroxyapatite crystals. Remember, materia alba is a concentration of microorganisms, desquamated epithelial cells, leukocytes, and a mixture of proteins and lipids with few or no food particles, and it lacks the regular intern pattern of observed in plaque. Next, when evaluating an osseous defect, the only way to determine the number of walls left surrounding a tooth is by a exploratory surgery. This is because a dense buccal and lingual plaque of bone will tend to mask the defect, blocking it out of the radiographs. This information can only be determined by exploratory surgery. Important, radiographs will not show the number of walls left surrounding the tooth, will not show the exact configuration of the defect, and will not show the location of epithelial attachment. Remember, the two most critical parameters for the prognosis of periodontally involved tooth are mobility and attachment loss. Angular defects are classified on the basis of number of osseous walls. Angular defects may have 1, 2, or 3 walls. The number of walls in the apical portion of the defect may be greater than that in its occlusal portion, in which case the term combined osseous defect is used. Pocket depth is the distance between the base of the pocket and the gingival margin. The level of attachment, on the other hand, is the distance between the base of the pocket and a fixed point on the crown, such as the cemento-enamel junction. Changes in the level of the attachment can be caused only by gain or loss of attachment and thus provide a better indication of the degree of periodontal destruction. Pocket formation causes loss of attachment on the gingival and denudation of the root surface. The severity of the attachment loss is generally, but not always, correlated with the depth of the pocket. This is because the degree of attachment loss depends on the location of the base of the pocket on the root surface, whereas the pocket depth is the distance between the base of the pocket and the crest of the gingival margin. Pockets of the same depth may be associated with different degrees of attachment loss, and pockets of different depths may be associated with the same amount of attachment loss. Next question. Angular defects are classified on the basis of the number of osseous walls that were destroyed? No. Number of osseous walls left surrounding? Yes. Yes, the number of osseous walls left surrounding the tooth. Horizontal bone loss is the most common pattern of bone loss in periodontal disease. The bone is reduced in height, but the bone margin remains approximately perpendicular to the tooth surface. The interdental septa and facial and lingual plates are affected, but not necessarily to an equal degree around the same tooth. Vertical or angular defects are those that occur in an oblique direction, leaving a hollowed out through in the bone alongside the root. The base of the defect is localized apical to the surrounding bone. In most instances, angular defects have accompanying intrabony periodontal pockets, including intrabony pockets, however, always have an underlying angular defect. Angular defects are classified on the basis of number of osseous walls. Angular defects may have 1, 2, or 3 walls. The number of walls in the apical portion of the defect may be greater than that in its occlusal portion, in which case the term combined osseous defect is used. Important, surgical exposure is the only sure way to determine the presence and configuration of vertical osseous defects. Osseous craters are cavities in the crest of the interdental bone confined within the facial and lingual walls. Craters have been found to make up to 1/3 of all defects and about 2/3 of the mandibular defects. They are more common in posterior segments than in anterior segments. They are best treated with osseous surgery, recontouring. The relative degree of success of periodontal bone grafting is reported to vary directly with the number of bony walls of the defect, vascularized, osseous surface area, etc., and inversely with the surface area of the root against which the graft is implanted. Thus, a narrow, three-walled angular defect usually yields the greatest success. A two-walled defect, the next best, and one-walled defect, the least. A dehiscence is a loss of the buccal or lingual bone overlaying the root portion of a tooth, leaving the area covered by soft tissue only. The three-wall vertical defect was originally called intrabony defect. The term intrabony was later explained to designate all vertical defects. The one-wall vertical defect is also called hemiseptum. Suprabony pockets are associated with horizontal bone loss. They are no intraosseous. Next. The periodontal differences between intrabony and suprabony pockets are the relationship of the soft tissue wall of the pocket to the alveolar bone, the pattern of bone destruction in the direction of the transeptal fibers of the periodontal ligament. Again, the principal difference between intra and suprabony pockets, relationship of soft tissue wall on the pocket to the alveolar bone, the pattern, yes. And next statement. In intrabony pockets, the base of the pockets is apical to the crest of the alveolar bone, and the pocket wall lies between the tooth and the bone. Both are correct. Distinguishing features of suprabony and intrabony periodontal pockets. Suprabony pocket, the base of the pocket is coronal to the level of alveolar bone. That is suprabony. 2. The pattern of destruction of the underlying bone is horizontal, suprabony. 3. Interproximally transeptal fibers that are restored during progressive periodontal disease are arranged horizontally in the space between the base of pocket and alveolar bone. Again, interproximally transeptal fibers that are restored during progressive periodontal disease are arranged horizontally in the space between the base of the pocket and the alveolar bone. And 4. On facial and lingual surfaces, periodontal ligament fibers beneath pocket follow their normal horizontal oblique course between the tooth and bone. Now, what happens if it's intrabony? Number 1, the base of the pocket is apical to crest of alveolar bone so that the bone is adjacent to soft tissue wall. 2, pattern of bone destruction is vertical or angular. 3, interproximally transeptal fibers are oblique rather than horizontal. They extend from cementum beneath the base of the pocket along alveolar bone and over crest to cementum of adjacent tooth. Number 4. On facial and lingual surfaces, periodontal ligament fibers follow angular patterns to adjacent bone. They extend from cementum beneath base of pocket along alveolar bone and over crest to again. On facial and lingual surfaces, periodontal ligament fibers follow angular pattern of adjacent bone. They extend from cementum beneath base of pocket along alveolar bone and over crest to join with the outer periosteum.